The condition that I'm testing is de Quervain's tenosynovitis, which we present as radial wrist pain. This can be present in all demographics. This is chronic microtrauma to the tenosynovium or sheath. This leads to stenosing tenosynovitis of the APL and EPB. Tenderness is often found a ½ inch proximal to the radial styloid. Some of the pathobiomechanics is a history of activities requiring forceful grip with ulnar deviation and repetitive use of the thumb. No imaging is necessary for this condition, and resisted thumb extension with ulnar deviation of the wrist would be the most affected range of motion, and there would be no change in MRS. So to perform this, you take your thumb, place it in your hand, and ulnar deviate the wrist. If this produces symptoms, then this test would be positive. The other condition that I'm testing is OA of the hip. My patient would present with hip pain and possible buttock, groin, or knee pain. This is found mainly in middle-aged or elderly patients. This is an insidious onset with slow stiffening, especially affecting internal rotation of the hip. Patient often walks with their hip held in external rotation, and they may also have low back pain due to the altered gait. Primary OA of the hip is a progressive degeneration of the femoral shaft of the acetabular articular cartilage and is thought to be due to microtrauma. Secondary OA is calcium pyrophosphate dihydrate crystal deposition, aka pseudogout, acromegalia, and hemochromatosis. X-ray is the best form of imaging for this condition. Range of motions that would be affected the most would be restriction to passive internal rotation and extension, and there would likely be no change in MRS with this condition. So what I would do is have my patient lay on their back. I would put their foot in a 4-4 position, and I would apply overpressure to the hip. If this presented with more pain or an increase of symptoms, then this test would be positive.